everyone, myself Dr. Prashant, and today we will be discussing the lecture about developmental dysplasia of hip. Originally, the name for this condition was congenital dislocation of hip, which was misnomer. Why was it misnomer? Because congenital dislocation of hip means the hip is dislocated since the child is born. But this condition, developmental dysplasia of hip, is not a disease entity, but a spectrum where the hip might be dysplastic. There might be just mild dysplasia to it can range from subluxation. It can range up to frank dislocation, or sometimes it could be irreducible dislocation, that is tetralogic hip. So this explains why the name CDH, that is congenital dislocation of hip, have been replaced by developmental dysplasia of hip over time to explain the nature of the disease, that it is a spectrum of disorder ranging from mild hip dysplasia till tetralogic hip dislocation. So this we have already discussed. Now coming to this radiograph, you can very well see that right-sided hip is appearing to be subluxated or dislocated. So this is one end of the disorder where dislocation is present. Coming to the other radiograph, you will see at 1 year of the age, both the hips are looking normal. But when we repeated this radiograph at 3 years of age, left-sided hip dislocated. So this is what I have explained already. The child was having dysplasia of the left side. He was not having neither subluxation nor dislocation at the birth. But as the child grew, at the age of 3 years, he developed this dislocation of the hip. So this is how the spectrum of the disease ranges. Coming to the etiology of the disease, there are certain factors like prenatal factors where a firstborn female child having family history of dislocation, that is DDH, and who is having oligohydramnios in prenatal period is at risk. Coming to the perinatal factors, in perinatal factors, frank breech presentation is another risk factor. Coming to the postnatal factors, we have history of swaddling. This is when a child is wrapped in a towel, leading to the adduction of both the hips, can also be a risk factor for development of developmental dysplasia of hip. So this is what we have discussed about the etiology of the disease. There are 5 F which defines high risk factors for a child to have DDH. What these F's are: firstborn female child having family history of developmental dysplasia of hip, having less fluid, that is oligohydramnios, and having frank breech presentation at the time of delivery. These 5 F will predispose a child to have developmental dysplasia of hip. And whenever anyone or more than one of these are positive for a newborn child, we should always screen the child for developmental dysplasia of hip. Screening will include both clinical examination as well as ultrasonography of the affected hip. So now we will be discussing about the ultrasonography of hip, which is a screening tool for developmental dysplasia of hip. To understand about the ultrasonography of the hip, we should keep the X-ray, plain X-ray of the hip side by side with ultrasonographic picture. So here you can see that left side hip is shown in this plain radiograph, where this is the ilium bone. Here we have triradiate cartilage, followed by further down you have ischium and pubic bone. Here you will have head of the femur. Side by side, we have drawn ultrasonographic picture where this is the iliac bone. Here, further down, we will have this triradiate cartilage. Over this region, you will have cartilage of acetabulum, and this pointy structure, whitish pointy structure, is the labrum. But the problem is that this radiograph and this ultrasound picture, they are taken in erect posture. But during ultrasonography of the child will be lying down. So the picture will be 90-degree rotated like this. You can very well see this picture have been rotated by 90-degree, where linear probe is lying over the lateral aspect of the thigh, and we will attain ultrasonographic picture which would again be rotated by 90-degree, what we have seen in the previous picture. So this is how you will have this ultrasonographic picture. So X-ray is rotated by 90-degree, and again this USG picture is rotated by 90-degree, where this is iliac bone, this part is the acetabular bone, This bluish structure is triradiate cartilage. All this region we will be having the cartilage of acetabulum, and this white pointy structure is again labrum. Now we will be discussing the schematic diagram of this ultrasonographic picture in detail. This whitish structure is the bony ileum. This one is the bony acetabulum. All this black structure is the cartilage of the acetabulum, and further down this greenish structure, it would be the triradiate cartilage. And this pointy whitish structure, as you all know, this is labrum. Now side by side we will be seeing all these structure with a schematic diagram. This is how I have explained all these structures to you. During the ultrasonography of the child, we calculate two angles. One is alpha, another is beta. And how do we calculate these angles? We have to draw 3 points. One point should be at an angle where this iliac bone merges with the acetabular bone. So this point would be the point 1. Second point would be at the center of the labrum. Third point would be at a point where this bony acetabulum is merging with the triradiate cartilage. So you draw an angle between these 3 points. Lower angle would be alpha angle and upper angle would be beta angle. So according to the numbering of these angles, we draw graph classification. In graph classification, you will have 4 types in simplified versions: type 1, type 2, type 3 and type 4, alpha and beta. And what these angles will be: in type 1, alpha angle would be more than 60 and beta will be less than 55 degree. In type 2, it would be somewhere between 43 to 60 degree and it would be between 55 to 77 degree. Type 3, it would be less than 43 degree and beta would be more than 77 degree. In type 4, both the angles become unmeasurable. So how these USG findings will look on the images, we will see. So graph classification, I have already told you, you should keep only this one in mind, simplified version, not the another one. And the management for type 1 to type 3 is mostly Paulich harness only. And for type 4, many a times closed reduction or open reduction is required. Again, you have to apply Paulich harness followed by this reduction. So this is how we manage these conditions. So a normal hip on ultrasound will look like this, where they have drawn both alpha and beta angle. Here alpha angle is 69 degree and beta is 45. So this is normal finding because alpha here is more than 60 and beta is less than 55. So this is a normal USG of a child. Coming to this type where alpha is less than 60 but still more than 43 and beta is more than 55 but this is less than 77. So this is type 2 graph classification. Coming to this one where the alpha angle is less than 43 degree, this is type 3 na? And beta is more than 77, that is 100 degree. So this qualifies for type 3 graph classification, and in this image we are not able to calculate neither alpha nor beta angle, so this would be straightforward type 4 graph classification. So how does normal development of hip occurs? We should first discuss about the femur. In femur, in a child, a common proximal femur physis develops, which divides into 3 as the child grows. So it will divide into the ossification center of the head and 2 apophyses, that is apophysis of the GT and apophysis of LT. So ossification center of the head will appear at the 1 year of age, of GT will appear at around 4 year of age, and LT will develop at around 8 to 10 year of the age. This is how normal development of the proximal femur happens. And when we come to the acetabulum, acetabulum growth occurs mainly at the junction of bony acetabulum and cartilaginous acetabulum. So this red is cartilaginous acetabulum and this orangish is bony acetabulum, and at the junction of the two, this green structure, the growth of acetabulum happens at the junction up to the age of 8 years. After 8 years, secondary ossification centers develop and the growth happens at these ossification centers, and at around the age of 17 to 18 years, these ossification centers will fuse. There are some important points that you should keep in mind, that in the acetabulum, the shape can change of the acetabulum till the age of 4 years if femoral head is present in the socket. After that, Even if the head is present in the socket, little will change for the acetabulum. So from this concept comes the fact of docking of the femoral head. So till the age of 4, if dislocated head is put back into the socket, it will change geometry of the acetabulum. And most of the time, any acetabular surgery, that is osteotomy of the acetabulum, will not be required if you have done your job before the age of 4 years. And if you are doing the surgery after 4 years of age, most of the times some osteotomy will need to be done for the acetabulum. Another fact which I have discussed with you is that the change of growth from junction of bony and cartilaginous acetabulum towards secondary ossification center. This was happening at around the age of nearly 8 years. So till 8 years of age, we can do surgeries for the developmental dysplasia of the hip, but after that age, nothing can be done. Now coming to the soft tissue abnormality which develops in developmental dysplasia of hip, if the hip remains dislocated out of the socket, are: one is pulvinar fat of the acetabular socket, it hypertrophies. Second is ligamentum teres, it also becomes thickened. Third is transverse acetabular ligament, it also becomes thickened. Fourth is the tendon of iliopsoas, it becomes interposed and it hinders interposing of this ligament. It will hinder relocation of the dislocated hip. Fifth one is hourglass constriction of capsule, particularly inferior capsule. And sixth one is neolimbus and limbus development. So in this picture, all these structures I will be marking. Pulvinar is 1, ligamentum teres is 2, transverse acetabulum is 3, tendon of iliopsoas is 4th one, hourglass constriction is the 5th one, and development of limbus and neolimbus are 6th. Limbus is inverted hypertrophied labrum, and neolimbus is hypertrophied suprolateral cartilage of the acetabulum. This bumpy thing. Both limbus and neolimbus are hindrance to the relocation of the dislocated hip. All these 6 points which I have mentioned over this slide, they all are hindrance to the relocation of the dislocated hip in DDH. Coming to the next slide, some bony changes will also happen over the time with dislocated hip. These are flattening of femoral head and flattening of acetabulum, that is dysplasia. And anteversion will increase with time. These are the changes which will happen in the bony part of the hip. Coming to the hip instability in a neonate. Supposingly a child is born in a nursery and you as an orthopedician receive a call that a child is born and we are suspecting that something is abnormal with the hip. Likely the hip is unstable. So what all we should examine in that child? We have to do 2 provocative tests. These are Ortolani and Barlow. We have all read about these tests. Barlow is dislocation of unstable hip. You adduct both the thighs and putting pressure from the medial side, so you are trying to dislocate the hip. In Ortolani, you relocate dislocated unstable hip. So we abduct both the hips and we put pressure from out in, so that we are trying to relocate the dislocated hip. And obviously if the child is at high risk, 5F we have already discussed, then we have to do a screening ultrasound for this child. Clinical features in a neonate will be provocative test will be positive, either Ortolani or Barlow will be positive, and the child will have positive Clisik sign. What positive Clisik sign is? This is how I draw a schematic diagram. Here ASIS are present for this child. Here the umbilicus is present, and here greater trochanter of both the sides. When we join greater trochanter with the ASIS on both the sides, these 2 lines will generally be intersecting above the umbilicus in a normal child. But if the hip is dislocated, like this greater trochanter, if this becomes upridden because of the dislocation, this line will be bisecting somewhere below the umbilicus. and this is what we call as positive Klissick sign. So in a neonate, we will have provocative test and Klissick sign will be positive, and abnormal thigh folds, that is classically defined, these will be positive. Whenever a child present to us as an infant after 1 year of the age, what signs will be present in this child? Provocative tests will be positive, but not always. Klissick sign will be positive, and Galeazzi sign. What Galeazzi sign is? When a child is lied down on a table and we look from the caudal end of the child, there is difference between the two knees because of the limb length discrepancy, that is Galeazzi sign. But among these, the most sensitive and most important is reduced abduction of the affected hip. This is the most important that you should keep in mind. When a walking child presents to us with DDH, what all we will have is Galeazzi and Klissick sign will be positive. Along with them, the most consistent finding was reduced abduction. This will again be positive. And apart from them, since the child has started walking, limb length discrepancy will be positive. And when the child starts walking, he will have limp. But this limp would be painless limp, that you should keep in mind. A child at around the age of 2 to 3 years coming to us with painless limp of the hip, this could be DDH, always keep in the mind. Okay, and apart from that, if the child is having bilateral condition, he can have increased lumbar lordosis. So now we will be discussing about the imaging of the developmental dysplasia of hip. There are certain lines which we draw in hip of any pediatric case. One is Hilgen-Riener line, one horizontal line passing through triradiate cartilage of the two sides. These are the triradiate cartilages. So horizontal line passing along the triradiate cartilages of both the sides is Hilgen-Riener line. And one vertical line along the lateral edge of the acetabulum. This one, over this part. Vertical line along the lateral edge of the acetabulum is Perkin line. So normally our head lies inferomedial to this. But whenever dislocation is present, it will go out and up like this. So this is how we draw Hilgen-Riener and Perkins line. And what is Shenton's arch? When we draw a line which is in continuity with the inferior margin of the superior pubic rami and continue it along the inferior aspect of the neck of the femur, a smooth arch, smooth line is drawn, that is Shenton's arch. And whenever a child have DDH, that is dislocation, secondary to the dislocation, obviously this Shenton's arch will be broken. Over this area, this is broken because of the dislocation. So all these three findings we should have in mind. There are certain classification systems which are defined in relation to the developmental dysplasia of hip. That is, one is Tony's classification and another is International Hip Dysplasia classification system. So these you should keep in mind. Now coming to the acetabular indexes, which are important in relation to the congenital dislocation of hip. One is acetabular index. How we calculate acetabular index is, firstly I will draw Hilgen-Riener line, a horizontal line along the two triradiate cartilages, and then I will draw one line from center of triradiate cartilage to lateral acetabular margin, this one, and this theta will be the acetabular index, and normally this is 25 to 30 and it would be even less than this. So obviously when a child is having dysplasia of hip, that is flat acetabulum like this, he will obviously be having increased angle. So this would be theta 2 and theta 2 is obviously more than theta 1. So acetabular index will increase when dysplasia is present. There are certain other angles also which we calculate in the cases of dysplasia, like lateral center edge angle of Weber, acetabular extrusion index, but they are not that much important. We do arthrogram in hip dysplasia cases after reduction or before reduction to know whether medial pooling of dye is beyond a limit. If the medial pooling of dye is too much, that is, if this is more than 4 mm, this is suggestive of too much soft tissue in acetabular socket, and which is a predictor of development of redislocation in future or failure of close reduction. In that case, many a times we go for open reduction and removal of this soft tissue. Age-based treatment for DDH is, whenever a neonate presents to us with developmental dysplasia of hip, we do only apply Pavlik harness. No need of even CR. Whenever a child presents after 1 month but up to 6 months, we do CR plus we apply Pavlik harness. But for all these children, whenever we have applied Pavlik harness, we ask the parent to bring the child at 3 weeks to us, and we reassess with a radiograph whether it is reduced or not. If reduced, continue it for 6 weeks. That is okay. If not reduced, we will give a rigid splint, or we can give spica, and then we will again reassess at 3 weeks. If it's still not reduced, we will go for open reduction. This is how we manage neonate and infants. But after the 6 months, if child is coming to us, 6 to 18 months child is coming to us, then most of the time we have to do close reduction, and sometimes open reduction might also be needed with hip spica. For 6 weeks have to be applied. Then we will reassess after 6 weeks, and mostly the job is done. Whenever a child is coming to us after 2 years of age up to 4 years, we have to do most of the time open reduction. Sometimes close reduction is enough, but mostly open reduction will be required. Plus we have to do shortening of femur, because after 2 years of age, if we do forceful reduction, chances of AVN will be very, very high. So we always do open reduction or close reduction with shortening of the femur, and then we apply hip spica for 6 weeks. Then we will see after 6 weeks, and most of the time the job is done. If the child is coming to us after 3 years of age, femoral docking will no longer be helpful. So we have to do some acetabular procedure. So what would be the treatment recommendation here? Most of the time open reduction plus femoral shortening. Femoral shortening plus acetabular osteotomy, and definitely hip spica for 6 weeks. This is how we treat these children. This diagram is showing Pavlik harness and its components. This is hip flexion strap, which keeps the hip in flexion. The posterior strap is hip abduction strap, which keeps the hip in abduction. This is chest strap, and these are the shoulder straps. These are the components of a Pavlik harness. And Pavlik harness is a brace or a device which achieves positional reduction. You don't need to do close reduction if the age of the child is less than 1 month. In a neonate, you don't need to do close reduction of a DDH. You just apply Pavlik harness, and this is a dynamic splint. Over the time, it will reduce the DDH. So this is how Pavlik harness works, and we apply it for 6 weeks. Even after 6 weeks, if we are not sure about the stability of hip, we can extend it for next 6 more weeks. But after that, the recommendation is not to extend it beyond 12 weeks. And obviously, as we have already discussed, after application of Pavlik harness, we do check reduction at 3 weeks by a plain radiograph. If not reduced, do apply either hip spica, that is cast, or a rigid splint. Even after that, if we repeat at 3 weeks X-ray, if not reduced, then we go for either CR or OR, that is close reduction or open reduction. This diagram is showing von Rosen splint, and this is Craig splint. Coming to the reduction of the hip, close reduction is basically a positional reduction. So what position we have to achieve? That is hyperflexion, more than 90 degree, and abduction in safe zone of Ramsey. Safe zone of Ramsey. What this safe zone is, we will be discussing in further slides. And sometimes internal rotation have to be done. What safe zone of Ramsey is? Supposingly, this is the arc which I am drawing. At 30 degree, if beyond this we bring the hip of the child, the hip dislocates. And more than 70 to 80 degree, the chances of AVN are very high. So in between these two extremes, an angle which we have calculated is safe zone of Ramsey, and we should always try to keep the hip in safe zone of Ramsey. So as there is no chances of redislocation, as well as there are very, very less chances of AVN too. This is how safe zone of Ramsey is defined. In this zone, chances of dislocation are high, and in this zone, chances of AVN are high. And in between the two zones, this one, the zone which I am going to mark with the green, this is the safe zone in which we should keep the hip while applying the cast. If the safe zone of Ramsey is very low for a child, then we can go for adductor tenotomy. Open reduction is needed whenever CR is not possible, or the close reduction is possible but this is forceful. or even after close reduction the hip is very unstable. And one thing which we have discussed is on arthrogram medial pooling was more than 4 mm. In all these conditions open reduction have to be done. Complications in DDH are: one is avian. In the first radiograph you can see that at the 3 months of the age the right sided hip was dislocated, and definitely they might have reduced it, but at the 1 year of age the ossification center for the right hip have not developed, maybe because of avian. This might have been because of forceful reduction of the hip. Another complication is redislocation. At 1 year of the age, on the left sided radiograph both the hips are on their place, maybe they have reduced the hip, but after 3 years right sided hip have been dislocated. So this is also one complication. Now coming to the osteotomies, femoral osteotomies, I have already told that after 2 years of age always go for shortening of the femur, because chances of avian are high after that age, because reduction is mostly forceful. If too much abduction is required to keep the hip in place, then we have to go for valgus osteotomy also, apart from the shortening. And in addition to the abduction, if too much internal rotation is also needed to keep the hip in its place, that is more than 10 degree, then apart from the valgus osteotomy you will require derotation also. So what all osteotomies on femoral side might be needed: one is shortening, another is valgus, and another is derotation, and that is VDRO, whereas derotation osteotomy most of the time this is needed apart from the shortening. Shortening is always required whenever the age of the child is more than 2 years. So most of the time femoral osteotomy that is needed is shortening plus VDRO, and this is the treatment plan you might have seen on most of the OPD cards of these patients: shortening plus VDRO. This we have already discussed. Coming to the pelvic osteotomies. Pelvic osteotomies we have already discussed. Before the age of 4 years, most of the time pelvic osteotomies are not required. After the 4 years of the age, if child presents to us, in that case femoral docking is no longer helpful for achieving acetabular molding, and in that case we will require some procedure on the acetabular side. And what these procedures are: 3 type of procedures have been described in literature. One is redirectional, another is reshaping, and third one is salvage procedures. So redirectional osteotomies are mainly Salter, double innominate, and triple innominate osteotomy. One is Gange osteotomy also. Coming to the reshaping is Pemberton and Degas osteotomy. These are reshaping. And in the salvage category we have shelf osteotomy. These osteotomies are a subject for another lecture, and we will be discussing them in another series of lectures. For this lecture we are just enumerating them for the sake of completion only. So these are the osteotomies we generally do in cases of developmental dysplasia of hip. This is schematic diagram showing that this was a dysplastic hip which have been relocated with the help of abduction of the hip, and since the abduction is too much they have brought the distal part in varus. So this is how they have done varus osteotomy. And if ever the internal rotation, if more than 10 degrees required, then they have to do derotation also. In that case it becomes VDRO, that is varus derotation osteotomy. So this is all what we have discussed about this entity, that is developmental dysplasia of hip. I hope that you find it helpful for you. Thank you.